Welcome. It's my pleasure to present to you on behalf of the IPA our webinar on developments in dealing with Parkinson's disease and its psychiatric manifestations. We is the IPA. Here you have a slide on what we are doing. And the IPA is dedicated to mental health of older people. It's world's leading multidisciplinary global psychogeriatric association. Next slide, please. The IPA webinars originated during the COVID-19 pandemic to help our members to stay connected online. The format is that we have two speakers on one theme, and that we have ample room for discussion afterwards. Next slide, please. I want to introduce before I introduce the speakers, here is an announcement of our next conference. It's in the Netherlands, it's in Leiden. And here is today's webinar. And I want to introduce myself. I'm Merle van Ooy, professor at Radboud University Medical Center, and I'm a medical sociologist by training, and I have the pleasure to chair this webinar task force. Our speakers are world-known experts on Parkinson's disease. The first speaker is Dr. Michael Okun, and the second speaker is Dr. Mateusz Zurowski. I will now introduce Dr. Okun, but not before I ask you to put your questions in the chat. We have approximately 25 to 30 minutes for discussion, and I will derive your questions from the chat. So it's very important that you put them in the chat. And all questions are welcome, and controversial questions, whatever, that helped us to learn more from Parkinson's disease. Our first speaker is Dr. Michael Okun. He is an American neurologist. He is a neuroscientist and a New York Times best-selling author. He is the co-founder and director of Norman Fixel Institute for Neurological Diseases at the University of Florida. He is recognized for his work in building new models of care for Parkinson's disease and for pioneering device-based therapies for neuropsychiatric disorders. And he will no doubt inform you about his latest book published in September. Dr. Michael Okun, the floor is yours.
Well, thank you so much. It's such an honor, and especially to be with both of the professors here today. And I hope that we have a really great discussion, because the discussion is where all the magic happens, where we all get to learn and share with each other. And so what I'm going to talk about today is I'm going to rocket through some pearls and some things about treatment in particular, and Dr. Zurowski is going to really highlight psychiatric aspects of Parkinson. And I just want to say from the start, I love the name of this society, the International Psychogeriatric Association, and the reason I love it so much is that we really need to be merging, care, and we're not providing enough care for folks with Parkinson. And it's one of the things that we talk about in our book, The Parkinson Plan. And certainly just want to let everybody know that all the proceeds to the book go to charity, and we hope that you join the movement to getting a plan for Parkinson disease. So this is our group at the University of Florida. We're just north of Disney World, about 2 hours if you happen to be in our area. I am supported by the National Institutes of Health and want to reach out and say thank you to the American taxpayers and for this institution for supporting my research. I'm a researcher as well as a clinician seeing folks with Parkinson's disease. Now, a number of years ago, we wrote a couple of books, and one of those books was called The Parkinson Treatment: 10 Secrets to a Happier Life. And in the prologue, I used two words, Parkinson pandemic, and it really set a lot of my colleagues' hair on fire, saying, how could you say we're having a Parkinson pandemic? And is the data really there to suggest that these cases are growing? And later on in 2019, we ended up getting more data. And this is sort of the drip, drip, drip that happens in science. And the Gates Foundation, the Bill and Melinda Gates Foundation, they funded cuts of data called the Global Burden of Disease Study. And now we know how fast Parkinson is growing. And we now have 12 million cases of Parkinson's disease in 2025, 11.8 million to be exact. And we had predicted when we wrote the book Ending Parkinson's Disease, so that's a book in between the Parkinson Treatment: 10 Secrets to a Happier Life, where we mentioned it in the prologue, and then a book that Bas Bloem from the Netherlands, which is where your next meeting is going to be, and also Todd Scherer, who at the time was the head of the Michael J. Fox Foundation, the CEO, and Ray Dorsey, who's the co-author of the current book. We together had written Ending Parkinson's Disease, and we had predicted based on the Global Burden of Disease study, there would be about 12 million cases in 2035. Well, guess what? We have almost 12 million cases in 2025 now. It is growing really fast, and this is something that whether or not you decide to use the term pandemic, which is usually reserved for infectious diseases or not, we can all say and agree that the number of cases on Earth are growing. So as we set off the alarm bells, I just want to remind everybody to be thinking about that. And also because we want to focus on care here today, I want to just mention to everybody that you all know this, but Parkinson's is extremely heterogeneous and no two people are alike. And the majority of folks who have Parkinson will do well, and it's different than Alzheimer's and ALS and other diseases. And so the Psychogeriatric Association, you can make a huge, huge impact. And so when we talk about this, each one of the letters stands for something in the book, but today I'm going to focus on the A letter, which is amplification, which is about amplifying our voices and also creating better care models. So when we think about amplification of voices worldwide, not everybody, you might be surprised, actually has access to dopamine. We work with the World Health Organization, and it turns out that 2/3 of nations all around the world don't have adequate access to dopamine. It's crazy, right? We have HIV drugs, we have all these cocktails, we can get things all over the world, but we can't get simple pennies on the dollar for folks. We still don't have telemedicine, both in the United States as something that is there for everybody, like we do in Canada, and Dr. Zurowski could probably comment on that more. And we need to increase our numbers of centers of excellence and reduce stigma. And it's really important when we talk about care that we amplify that message. And probably the best example of this was the March of Dimes, where people mailed dimes to the White House in the United States. And this is FDR and comedian Eddie Cantor and putting a face on a disease and creating really that movement that's important. In HIV, we saw the movement here where the people got pissed off and they went to Wall Street and they shut it down because the price for the drug companies was too high for HIV drugs. They did a peaceful sit-in of the Food and Drug Administration. You can see here. They also put a fake condom on top of one of the politicians' houses, saying that he was unsafe politics was deadlier than the unsafe virus, and nobody voted against HIV after that, and it changed the trajectory. How fast is Parkinson growing? Well, we can talk about it in our second group when we have our group discussion, but we used to say that it was every 9 minutes, but now every 6 minutes somebody's diagnosed with this. And we need a new care plan. And this is the care plan that we proposed in our book, The Parkinson Plan. Patient is the sun, the person is the sun. We should orbit around the person. Mercury is the caregiver. It gets hot being the caregiver. And then also you're the messenger. Remember what Mercury is. And then all the other planets They are all the multidisciplinary specialists that we need, including psychogeriatrics, movement neurologists, other disciplines. The satellites are all those wearables and telemedicine and things that we can use. Of course, the stars are your support groups, and we need a mission control that's going to help us to coordinate the care like we have for HIV and for cancer. And we can't forget about Pluto, that is that almost planet that's out there, and that stigma. And 25 to 50% of people, depending on what study you read, actually will hide their diagnosis of Parkinson, which is unacceptable. And the asteroids are all those things like access to care, cost of care, transportation, parking, payer systems. And this is true across the world. There are many asteroids to the universe. We have to think bigger, like we do for HIV and like we do for cancer. So when we think about pearls, you need to first thing realize that when you say you have Parkinson disease, so all the psychogeriatricians here, remember those words will be, like heat, seeking missile will be in the brain the moment that it happens every time that you give that diagnosis. So pause and remember what it means. And also remember to explain to people they don't have Alzheimer's, they don't have ALS, they don't have brain tumors. They think they have these other things. They don't have any context. And so it's important to give them context to tell them what they don't have. And remember, when you're giving medications to people, even when you start, you have to remember to tell them that the right thing at the wrong time is the wrong thing, and timing matters. And timing of medications is going to change, and you have to take a careful history with folks and be really, quite vigilant about when do things kick in, when are they wearing off, how are things changing, and we need to think about both these motor and non-motor symptoms like depression, anxiety, and cognitive dysfunction, sexual dysfunction, apathy. Does seeing a neurologist matter? It turns out it does. This is Alison Willis's work showing that it decreases morbidity, mortality, and nursing home placement, even decreases hospitalizations. And if you're on dopamine, remember simple things. Make sure you have people on a multivitamin, has some B12, folate, and B6, not too much B6 because you don't want to give them a neuropathy. But remember, psychogeriatricians, it increases homocysteine, right, which increases your cognitive risk. And so this is something that I don't know why people don't pay attention to, but we should, as a society, pay attention to it. Twice the risk of malignant melanoma with Parkinson's disease. So see a dermatologist once or twice a year. Parkinson folks sweat differently. And in fact, Parkinson isn't just a brain disease and is not just a disease of dopamine. It is a whole body disease, and we find it in the gut and other areas. Make sure you sneak up behind your people, psychogeriatricians, give them a pull and a tug and see if they can correct their balance. One of the best ways you can tell whether or not they need assistive devices or help. And in fact, with the increased fall risk, did you know twice the risk of osteoporosis and osteopenia in Parkinson, even in men? It's more common in men. Parkinson's disease is, and both men and women get osteoporosis, but we don't think of it enough. And so screening and treating and being proactive is really important. Having a plan. 1 out of every 2 people are going to end up in the hospital with Parkinson's disease. 1 out of 3 each year. And then once you've had your first one, it's going to be 1 out of every 2. So we need to have a proactive hospitalization plan. There's a free hospital safety guide we made with the Parkinson Foundation. Remember, exercise is a prescription. There are lots of different ways. Best exercise is what people are willing to do, but also getting folks on regimens and realizing that it's going to be different for different people. Be careful of nutritional overreach. People will tell you, you do this, do that, your microbiome, do all these things. We actually don't know yet how to perturbate the microbiome. And so we have to be careful. And I think that we have to tell people also, you tend to lose weight over time with Parkinson's. So better to be a little higher than your ideal body weight rather than a little lower. People with Parkinson's disease, 2.6 times more likely to be demoralized. And so we think about depression, we don't think about demoralization, and demoralization is normal in a chronic disease. We need to recognize it and treat not only the depression and the anxiety, but demoralization and apathy. Making sure folks are sleeping. You want to get your sleep times up to 5 to 7 hours at least a night. And in fact, 7 to 9 hours would be great, but you can't do it if you don't monitor it. So thinking about monitoring folks and not just getting one sleep study in time and helping folks to sleep is going to help all the symptoms of Parkinson's disease. Pain has been reported in 3/4 of folks with Parkinson. We tend to shy away from it. It's something we should ask about, and we should have a plan for how we look at pain in Parkinson. And of course, Dr. Zurowski is going to talk about psychosis in Parkinson disease and all those demographic and disease-related factors, pharmacology, cognitive, behavioral, medical, environmental. What can I tell you about psychosis is this. If you see somebody who has psychosis in your clinic, don't think you're going to see them once and you're going to be one and done. You really need to have a plan and be seeing people frequently until you get them out of trouble. And there's a lot of factors that will lead to hallucinations, to delusions, and to both auditory and tactile and sense of presence can sometimes occur. And we need to be ready with a plan for those folks. And remember, stigma is big. We need to get rid of stigma in Parkinson's disease. The only way we're going to do that, that's that planet Pluto, is we're going to start to normalize this and tell people it's okay to have Parkinson's disease. And it's unacceptable that 25 to 50% of people that have Parkinson's disease have to hide their diagnosis. So we have a Parkinson 25 in the new Parkinson Plan book to help people both with and without Parkinson to live a better life, and also think about what you can do to be proactive. I think proactive is super important. And I'm right at 12 minutes here. And so thank you to this society for giving me the chance to prime you up for some things we can talk about. And I'm going to ask you, are you going to be street smart or are you going to be book smart? And I hope during our discussion, we get to the street smart side of the equation. So I'm going to turn it over to Dr. Zurowski.
Thank you. Thank you so much. And also for keeping in time. And I enjoyed your vivid, comprehensive overview and your activist approach. And I think we will hear more about it during the discussion. And now I have the pleasure to announce the second speaker. It's Dr. Mateusz Zurowski, and he is going to talk about Parkinson's disease, psychiatric perspective. He is a psychiatrist practicing at the University Health Network in Toronto over the past 20 years. His outpatient practice, he has an outpatient practice, and that is devoted to patients with various mood disorders and primarily those of Parkinson's disease. He does research at the Trimble Brain Institute, and he is an assistant professor at the University of Toronto. Dr. Zurowski, the floor is yours.
Thank you, Dr. Farnui. I'm very happy to be here, and thank you very much for your kind invitation. I am so humbled to be following Dr. Okun and the vision that he proposes for this illness, the Parkinson's disease. It is a vision that we should all follow as best as we can, developing a pathway for patients and supports for them as they go through this illness that is imminently treatable. And as he mentions, it is an illness that we can make a huge difference. So I'm very happy to be presenting on this topic, especially since I looked at the program from your conference last month. And I was saddened to see that there was no Parkinson's on it. So I am so happy that you have invited us to speak about it. I have no declarations here to make. One thing that I'd like you to keep in mind is that I will mention medications and so on, some of which are not approved for these purposes. I will talk about the non-motor aspects. I will really want to emphasize how important dopamine is, not just for neurologists, but also for us, psychiatrists, as we see patients with this illness. And also emphasizing how important we can be and how helpful we can be in treatment. Now, as you know, Parkinson's is a motor illness. That's what brings patients to be seen. They cannot move well. However, they have mood problems and demoralization. They have anxiety, they have cognitive problems, they can develop psychosis, dysautonomia such as constipation, motivation and apathy problems, pain problems, fatigue, sleep. Sleep is so very important. I was so glad to see Dr. Okun mention it in his presentation. It's one of the things that I pay a lot of attention to every time I see someone with Parkinson's disease. So as you hear, the motor is the initial, but as time goes on, these other elements of the illness, these non-motor effects, really take over. And this is where psychiatry, geriatrics, other specialties become so very important as we try and improve the lives of individuals with this illness. There's also an illness of transitions. There's a progression. I've labeled early stages, middle stages, late stages. These are somewhat arbitrary, and yet initially this illness is so well controlled it's invisible. And then as the illness goes on, it becomes increasingly visible, increasingly interfering in life, inability to stay employed, ability to really perform IADLs, increased dependence, eventual hallucinations. So, and this progression is so highly variable. I completely agree with what you've heard earlier, that not each person with this illness is different. Each illness is almost different, and it's perplexing, and yet it's also so very hopeful. Medications that I used are the neurology medications. Now, I put them up here because as a psychiatrist, it is actually one of the key things for me to understand. I have to understand what my colleagues in neurology are doing with their medications and how these medications are working for the patients that I see. Because the other medications, the anti-apathy agents, such as the SSRIs, the benzodiazepines, sleep aids, clozapines, stimulants, these agents are more our sphere. We should already be fairly familiar with them. Of course, we have to understand how they interdigitate with the neurology agents. But understanding what neurological agents do with patients that we see and tracking it actually really helps to inform how best to be effective. And this is a key slide because what happens with dopamine is that it doesn't just affect the motor part, the back arc, the akinesia, dyskinesia, which the neurologists are working very hard at putting in the right zone. Patients need to be able to move well, not too little, not too much. But also the same medication, the same dopaminergic medication can actually also alter learning. So patients don't learn from positive experiences. They're just bound in the negativity, or they don't learn from the negative experience. So all they're looking for is the pleasure. And they're looking, in Canada, we have this Fallsview casino ad that somebody comes out of the casino with their arms up. They're just looking for the arms up feeling. Again, that's not a good place to be. And the same with mood. Initially, with the depression, which is quite common at the time of diagnosis, whether it's a psychological response or a dopaminergic story, you need the dopamine. But too much dopamine and you get mania-like symptoms, attention problems. Again, so as a psychiatrist, I have to pay extreme attention to what's going on with these these dopamine agents, but also the dopaminergic agonists, as they're called, which are not levodopa. These are medications like pramipexole, which can push people a little bit more to the right side. Another way of visualizing this is these boxes, as that somebody takes levodopa, or dopamine, which is the vertical arrow. It can swing through these things, and you got to pay attention. How does it swing? What's going on here? Because what happens is, yes, we want to treat the motor element of illness, but also what happens with dopamine, it treats emotion and motivation, and we can actually hyperpotentiate it. We can cause problems. And understanding what is medication doing versus what is illness doing is important, because medications can cause impulse control disorders, especially in patients who are younger, 50s, 60s. They can have pathological gambling, hypersexuality, excessive shopping. They can have excessive cravings for sweets. These are the patients that gain weight, but not just a little bit of weight. So if a patient with Parkinson's is gaining weight, too much weight, you got to really think, what's going on? What are they eating? And yes, I completely agree with what you heard earlier. Patients that lose weight, I worry about even more. because sometimes patients lose weight because they figure out that their dopamine doesn't work as well when they eat. So when they have a full belly, dopamine doesn't work well. I want dopamine to work well. I'm not going to eat. These patients come across as anorexic sometimes, and they get into huge problems. Patients can develop excessive dopaminergic intake. They seem to always be dyskinetic, and they are always taking medications, and you never see them otherwise. And because they're so afraid of going off, not being able to move. They can have excessive daytime somnolence from their medications. So initially when medication like pramipexole was released, people would fall asleep behind the wheel of a car and have accidents. Again, understand these medications, because it's really key to broaden that armamentarium that we have, not just to understand the psychiatric elements, are they anxious, depressed, but also understand, okay, what else is going on here that I need to speak with my neurology colleagues about to try and figure out how best to go forward. Visual hallucinations can be illness, can be medications, again. And as the illness progresses, of course, you get some cognitive difficulties, but even cognition is to some degree affected by the medications that patients take. So being very careful in listening. Anxiety is probably the biggest problem that I see in patients who are in their 60s and 70s. And part of this anxiety is the relationship between mind and body with these patients. When patients go off, they can be very anxious. When patients are stressed, their medications don't seem to work. So all of a sudden, after they've taken the medications, and something happens that stresses them out, the medication is not effective at all, and they're stuck. And this is where you sometimes see patients really, they become shut-ins. They stay at home because they don't want to risk it. At home, they know exactly how their body's going to function. They know where the washroom is, where the kitchen is. They don't get stressed the same way. So they limit, they become avoiders, which is the anxiety, as psychiatry how we call it. And yet there's something peculiar here, with the medications actually, as much as anything else. And to understand this a little bit, I've put up this graphic to show how motor function is actually initially incredibly well controlled. The arrow, as you saw, is always in the on part. As illness progresses, patients can dip into becoming off, so more tremulous, more slow, bradykinetic. Or they can overshoot, become dyskinetic, and then undershoot, and this can happen multiple times in a day. So patients will take levodopa 5 times a day, every 3 hours, sometimes even every 2 hours. And what happens is they go between the on and offs. And when they go off, or they go dyskinetic, they can get anxious. Again, listening to this, okay, what's going on? The neurologists are always looking to extend the on motor, and what's going on that patients are dipping into the off and maybe going earlier to something that's a pump system for dopamine delivery, maybe trying to do something with the dyskinesia, because again, we can start an SSRI, and yet if this is the story, dopamine is a strong, strong drug, and we need to pay attention to it, and SSRI may not be always the best way to go. I'm going to stop there because my time is up. Unfortunately, I will not talk about psychosis, although there's a lot to be said there, and other elements that are psychiatric of this illness. And I thank you for your attention.
Thank you so much, Dr. Zurowski. I enjoyed you taking us through the Parkinson's journey, and especially focusing on the importance of what I would like to call personalized medicine. Now, the floor is to all people who are in the audience now. We have the opportunity to have a discussion with two great speakers. And if you have a question, please tell us for whom the question is, and put your question in the in the chat. Here is the first question. It's from Zara Laundry. Thoughts about the newer antipsychotic brexpiprazole for psychosis in Parkinson's disease. Also wondering about thoughts with regard to long-acting aripiprazole for psychosis in patients refusing oral medicine. I think that might be for Dr. Zurowski.
Thank you, Mara, and Zara for asking the question. I didn't catch the name of the first medication.
Well,
aripiprazole and brexpiprazole.
Brexpiprazole, yeah.
Aripiprazole and brexpiprazole, and
Yeah.
also the question about long-acting intramuscular aripiprazole for psychosis.
You know, I can speak to aripiprazole. It does worsen Parkinson's, unfortunately. So even I do have a few patients that take it, I gotta say, because when I've tried to take them off the medication and switch it up with an antipsychotic agent, they've been intolerant and they've actually decompensated markedly. So sometimes I will use it in 1 or 2 milligrams, but it's very rare because I do see it as worsening their motor symptoms, and I'd like to avoid that. And I would like to avoid destabilizing their illness, which is another concept that we sometimes touch on with these agents causing dopaminergic blockade. So I try and stay away from it. The long-acting, I mean, the similar problem. Like once you get it in the system, you gotta wait for it to come out and you worry. I don't know if Mike, you want to add anything to that?
So I 100% agree with you. Aripiprazole definitely worsens. Less is known about the brexpiprazole, used mostly in Alzheimer's, folks, and the suspicion, there's not a lot of data, is that it won't be awesome in the Parkinson realm. We tend to use quetiapine for sleep, and remember, if you improve sleep, you'll oftentimes improve psychosis. And that's probably why a lot of these studies didn't reach their primary outcome. But a lot of people who use it say, oh, well, it gets better. So if people are not sleeping, and that's why monitoring the sleep, and getting a ring or a watch or, something that you can see daily what's going on. And then you realize sleep's going to be fragmented in Parkinson. And so I think working on the sleep also helps there. And then so that's where the quetiapine might come in. And then, of course, clozapine and pimavanserin are two that can work without worsening the Parkinson symptoms. That tends to be our toolbox. We would like to have a bigger toolbox, but that's where we are right now.
So I'm going to just throw up this slide briefly if I can. Oh, no. I have a slide that basically shows that psychosis is not psychosis with Parkinson's. That visual hallucinations can have a lot to do with medications, can have a lot to do with sleep disturbance, as Mike is saying. Like normalizing sleep is really, really, really important as an initial step with these patients. And there are certain dopamine, levodopa itself tends not to cause visual hallucinations. It's more the sleep disturbance, perhaps dementia. So keeping people on the dopamine, as opposed to, and changing up the other things that are perhaps less relevant or more likely to induce psychosis. So there's an approach here that's really important, but realizing that unlike in other illnesses, perhaps like schizophrenia, psychosis can all be a little bit different and can have different causes and different remedies. So yes, we can reach to the antipsychotics, but that's not the first place to go.
Thank you for these additions. There is another question related to what we just discussed, and I complimented both of you for the individualized approach, but Dr. Hassam, he asked, would there be a general strategy to manage apathy and anxiety? So not only focus on the individualized approach, but also general strategy. Michael, can I ask
Yeah,
you
so
a question?
the two A's are anxiety and apathy, and then I'll also say there's impulsivity too. A number of our former fellows have done papers that actually can show you can in Parkinson disease actually be impulsive and apathetic at the same time, which is a really crazy like thing to think about when we're thinking about psychogeriatrics medicine. But that's what makes this field so interesting and so fascinating. On the side of anxiety, I always start with how anxious were you before you had Parkinson? I think the discussion should start there. You know, like, did you have a generalized anxiety disorder, or were you very anxious or very type A? And then second, what's the effect of dopamine? Because a lot of times the off anxiety is due to wearing off, and people are not paying attention to timing, dose, and optimizing. And so you need to know, is it off med, on med, and could it be a dosing phenomenon? And shortness of breath and going to the emergency room can oftentimes be anxiety related from the off and from wearing off. And so we want to know, does it have an effect with dopamine? And then third, are you younger with Parkinson, or are you more seasoned? I never say older. And are you more seasoned? And when you're younger, you tend to have more anxiety. There's lots of papers now showing that men in their 50s, anxiety might even be the first symptom of Parkinson's disease. And so we have to key in on that. So response to medications wearing off, these non-motor fluctuations, timing matters. Watch the emergency room on that side. And then a lot of these sedatives are not awesome, like so I'm not like a huge fan of benzodiazepines, and so people have begun to start to look at other things to treat this with. And so we've seen a lot of information on THC, which has its positives and negatives, and CBD, which has its positives and negatives. We've seen psilocybin, there's a trial out in UCSF. And so we desperately need more therapies for anxiety. I do think that using things like SSRIs and SNRIs can be useful, but be careful not to push them up so high that you make the person apathetic. So now talking about apathy, apathy is very hard to treat. If you stimulate the dopamine receptors directly with things like dopamine agonists, there's lots of literature showing you can activate people, maybe even make them impulsive too, and you can go too far on that side. So we've tended not to do that, and very rarely will we use a tiny dose of a dopamine agonist to get somebody going. We tend not to do that, but occasionally you never say never on that side. We don't have a lot of great, medication treatments, and so we have, at least in our center, and I'm interested to see what Dr. Zurowski does as well. We use what's called a PALS program, PALS, which was a cognitive behavioral technique that was developed by London Butterfield, who was a former psychology fellow here at University of Florida, who's now at University of South Florida. So we use a lot more behavioral therapies, approaches, and trying to help people on the base side. But what do you think, Dr. Zurowski? I'm interested to know what your thoughts are.
Thank you. Yeah, I mean, these are really important questions because, again, differentiating what's anxiety, what's depression, what's apathy, and trying to look at that spectrum, because sometimes it comes across as apathy, but it's actually anxiety, and what do you do? And then trying to figure out, when is the anxiety? Is it anxiety between 2 and 4 in the afternoon every day? What is that? What kind of anxiety do people get between 2 and 4 in the afternoon as opposed to at other times? Because the only things that are time-bound are really medications. They're taking their levodopa every day at the same time. And if anxiety is time-bound, then I start thinking, okay, what's going on here? Or maybe it's their spouse that's coming home at 2 o'clock every afternoon, and that's what stresses them out. What's going on? Because that leads to intervention, possibly, especially if it's very circumscribed. So careful history. And then apathy, when I introduced the antidepressants, I called them anti-apathy by mistake, but these are apathy agents to some degree. What are the antidepressants doing? Are they causing this? Are they contributing to this? What's going on in terms of their routine? So yeah, getting into a routine, getting somebody to participate with the patient from their family or their trusted care group, that they can get into a routine. Because once all of us get into a routine, everything gets easier, everything gets smoother, everything gets a little bit stress-free. So for sure, you want to go with these kinds of ways to see whether they can actually help an individual get out and live a fuller life. I talk about people with Parkinson's shrinking their lives because, and it's as much about anxiety as it is about movement. There is something about tremor, for instance, it's almost overvalued by these individuals. It's other patients with tremor don't do it the same way. Essential tremor, they don't withdraw the same way as patients with Parkinson's. What's going on here? There's something unique here. And more trials for that anxiety definitely need to happen. We don't actually have any really evidence-proven treatments for it, by the way, I don't think. But so getting people engaged, yes, a little bit of dopamine agonist can help. A little bit of a stimulant sometimes, yes, I will use that. But yes, trying to get people engaged, getting them involved is part of what I try and do through all of this assessment and modification of whatever it is that they're going through.
So not only the focus on medicine, but also on psychosocial interventions. That's I think very typical for your approach. And there's another question from Fatima Amdes. How to distinguish Parkinson's psychosis from Parkinson's dementia? Maybe I can ask Dr. Okun to answer.
Yeah, I'm going to punt that one really fast. I will say this. So I think that we just have to consider, no two Parkinson cases are alike. Okay, one. Okay. Two, that when you if you see psychosis before you see dementia, scratch the surface because there probably is cognitive dysfunction there. Okay. Three, when you get neurocognitive testing, and I'm a big fan, we train a lot of neuropsychologists here at University of Florida. They're just a fantastic group and PhDs, and sat on a lot of committees. And I've become a big believer in testing folks and in interacting in this way with behavioral therapies and behavioral diagnoses. And you'll know that the folks with Parkinson, if you follow them, they will all develop frontal and memory dysfunction. And then as you follow along, we have these cognitive superstars that tend to stay, very preserved, at least for sometimes long periods of time, sometimes even decades. But the majority of people are going to pick up cognitive dysfunction. Where you decide to call that dementia depends on how closely you look and what criteria you apply. And in some sense, when you're taking care of somebody, it doesn't matter in some sense. What matters is you pick up that you have, something that you need to think about and deal with. When they have psychosis, okay, most of the people with psychosis have more cognitive dysfunction associated with it. Now, we do have folks who have mild amounts of illusion solution that are non-bothersome, non-threatening, and insight. Insight is the key. I always think about, do you have insight or do you not have insight, in terms of how aggressive we look at that. But those two are bedfellows, if we can. I don't know if people still use that cliche term, but when you see psychosis and you see cognitive dysfunction, usually those two go together. Of course, medications can bring it out, as Dr. Zurowski really, I think quite poignantly taught us. And I think that we also have to realize that we have simplified the field. And since you all are psychogeriatricians and in this field, just remember, a lot of times it's more than one thing going on in the brain. And so always remember, when you see psychosis and you see cognitive dysfunction, ask yourself, am I purely dealing with Parkinson's, or am I dealing with Parkinson's plus a little Alzheimer's, a little bit of vascular dysfunction? Could there be another disorder? And most of these people, when they go to autopsy, are going to have more than one pathology, and we just haven't come to terms with it yet. But I'm talking a long time because I don't know the answer to this question. So I'm going to give it over to Dr. Zurowski, who's probably much more attuned to the real answer here.
Yeah, no, I think we're all struggling always. I mean, I remember when I was doing research with individuals who were just newly diagnosed with Parkinson's disease, and we're doing the frontal assessment battery. So it's a very simple test out of 18. People were working in high-level jobs were already scoring 17, 16 out of 18. Is that anxiety? Is that something else? What's going on? Again, at what point do you call that a dementia is always a question, because there is a cognitive something that's going on a lot of the time, and some of it is about having dopamine in the right range for cognition and attention. The other thing is always sleep, and it's a really interesting thing because patients will describe about being in a fog, feeling out of it. What is that? What is the sleep disturbance there? What is possibly a REM intrusion, which is another hypothesis people have floated? There is more to this, and understanding what is it that you're treating. Do you need to treat it? There is one study that shows that quetiapine delays progression of psychosis to the point of losing insight. Is it worth it? Is it worth subjecting somebody to that kind of an agent for years? These are questions that I think are very much relevant for our field and need further understanding.
Thank you. I have a question myself. There are enough questions, but I'm really curious about it. The progression is highly variable. And are there modifiable risk factors who influence the progression?
So you're talking about trajectory. So you think about, okay, so if Parkinson isn't one disease, and a lot of people refer to it as Parkinson's disease, then it's really frustrating if you're a clinician and even a person with the disease to come in and not know, like, what course am I going to take? What trajectory am I going to take? Now, we are getting a little bit better each day, I think, on this, and part of it is will we reach that point that, like where there's an inflection, where we change our direction and we're able to change our clinical practice. And so we're seeing multiple things. Like, this might be an area where AI is starting to apply itself. There was a paper by Sue and colleagues from Cornell. There's been many other papers, like, starting to look at these large databases and see if you have, for example, REM sleep behavior disorder, there seems to be more association with cognitive dysfunction later on. If you have certain things, and so the ability for some of these large data sets, and then eventually to see algorithms that might tell your clinician, okay, you're dealing with this particular type of Parkinson and it might progress in this way. Now, having said that, the more experienced, people, we call them the more seasoned people that have been around the block and seen a lot of Parkinson folks, they have like a sixth sense, and they might not even know why they have a sixth sense, but they've just seen a lot of people. And the more times you get to see somebody, the more shots on goal. If you're a sports person, the more times you get to see somebody, the more you'll get a sense. You can map their trajectory right over time, so you'll be able to give them, some idea of what their course is going to be. And then also certain things like presence of a resting tremor seems to be better than if you don't have a resting tremor. So there are things, presence of REM sleep behavior disorder may be worse for some people. Presence of some genetic abnormalities like the GBA1 linkage, association of Parkinson's seems to be worse. So putting together some of these things. But what's the most important thing, I think? Seeing the person multiple times, being humble, realizing that every day we practice medicine, we know a little less, and sometimes we are fooled. And so we have to always keep our eyes to see, is it going to morph into something different, or might there be a co-pathology along with it? But the best favor you can do for your individual folks is try them on dopamine and follow them over time and see what they do, and then be very humble. And each time you see them, examine them and ask yourself, did I miss something? Could this be PSP? Could this be MSA? Having said that, there are now some emerging tests that, that we're starting to see in its early days, and I think we're going to have to combine them together. But there is even a test with AI that we were part of a National Institutes of Health study in 21 centers where an MRI, something that you can't see with your eyes, can now tell the difference between Parkinson, progressive supranuclear palsy, and MSA. And some of those things, I think, could be very useful to see those come out into practice to helping people, one, get the right diagnosis, two, some people convert with multiple co-pathologies, and three, just see your folks as much as possible. So, Dr. Zurowski, what do you think?
I would agree. It's there's been a lot of different trials. Like I think Azilect, I remember rasagiline was tried at one point as a disease-modifying agent, wasn't successful. There was a couple of recent New England Journal publications, unfortunately not successful in terms of Lewy body treatments. The only thing that's really seemed to so far change the trajectory is exercise. There was a study that 3 times a week, 30 minutes at a time, getting the heart rate up to, I think, 110, seemed to make a difference for trajectory for the patients who did it versus the patients who didn't do it. So we always propose that, it's a great strategy anyhow. It maintains bone health, helps to maintain muscle mass, it helps psychological anxiety features. So, and it delays illness. I mean, this isn't a win-win if an individual can do it, and knowing that it changes trajectory of illness is extra motivating.
Thank you. There is a question related to exercise. It's from Maria Moore. And she said, I just read a recently new paper that discussed the benefits of playing ping pong to help with the disease. What other exercises which can be performed alone or in a team would be recommended?
You want me to start on that one, or you want to start?
Yeah, go for it.
Okay, I'll just start on it and say, first of all, the best exercise is the exercise that you're willing to do. Okay, like let's just start there. 2, there are super exercisers that we see in our practice, and we have to be careful with the super exercisers. These are people that are like so above and beyond, and they've read some of the papers about forced exercise with my good friend Jay Alberts and everything, and they go to such high levels that they actually become too tired and too fatigued, and we actually see this actually not infrequently in the practice. And so for super exercisers, I always recommend that you get in line next to the cardiologist. So why do I mean by that? Well, the cardiologists, they dominate the testing for how healthy you are for exercise. They're called VO2 max testing. And so they're dominated by all these cardiac patients. And so the super exercisers, in my mind, should get a VO2 max. It tells you a good baseline of where you are with health. And then we should be using our physical therapists and resting if you're exercising too much. Having said that, we know Google data tells us that about 7,000 to 7,500 steps a day, you'll live longer. Not everybody wants to live longer, but exercise, as Dr. Zurowski mentioned, is the big thing. Like all of the guidelines have changed now. All of the experts are now prescribing it. If you're not prescribing it, then you're missing the boat. And the real question is how do we prescribe it, and what sort of plan do we get people on? So I always start with, let's see if we can get you to do something every day. 2, if you could get to 7,000 steps a day, which is really actually hard, that's 4 20-minute walks. And certainly you don't want to do that if you are at any risk of falling in balance, and you definitely want to have somebody walk with you. But if you can spread it out into 4 or 5 walks, to make that happen in a day, that the Google data, that's data that doesn't need a statistician, suggests this is very good for your health and very good for Parkinson. I mean, it's just very obvious, okay? If you can't walk, then recumbent biking is great, and you can even get an exercise cycler for under your desk. You can put the exercise cycler in front of people so they can have the back of a chair, and better to do that in a safer area. And then, of course, if you have one that moves, make sure you're helping people so they don't trip over it. Ping pong is great. Tai Chi is great. All of these exercises are great. There's even an article in New England Journal of Medicine about it. And so it's less about which one and more about what's good for you. And please, please, please don't forget about stretching. Like stretching is so important, and getting stretching bands and learning how to stretch. It's so underappreciated in Parkinson, but it makes such a difference for folks. So, Dr. Zurowski, what do you think?
Oh, no, I'm sorry, Mara.
Yes, can I ask you something about exercising alone or exercising with other people? Do you have a preference, and why? Maybe
Yes.
Dr. Zurowski.
Oh, yeah, I'll go for that one. I always prescribe going out. I don't like people to exercise at home because people don't exercise at home. We all know what a treadmill at home looks like. It's a clothes rack. You know, the same with bicycles, like people tend not to use it. But the other part is that I want people to be with others. This is a lonely, lonely illness. And one of the big things, and the thing that's most stimulating for all of us, is actually other people. We open ourselves up to the world, to other ideas, to different concepts. The world becomes richer, and we are less afraid of others when that happens. So I always prescribe like going to a gym. Like even if you have a treadmill at home, go and use it at the gym if you can. That's for sure, that's my preference. One other caveat I would add, though, is that there are some individuals who every single moment of the day they do something for their Parkinson's and they forget that really life is about living as opposed to getting their Parkinson's better, making sure the diet's good, the stretching's good, the exercise is good, they do yoga, they do dancing with Parkinson's, boxing with Parkinson's, everything is Parkinson's. That's when you need to take a breath.
Okay, and when you take a breath, I take the opportunity to give the floor to Rob Medan.
Thanks, Mira, and thank you to our speakers and for everybody for coming. So the question is, there's part of it's in the chat here. So I guess I have two questions. One is, we have lots of antidepressants. I see lots of geriatric depression in the context of Parkinson's disease. And Mateusz, before I remember you've spoken to me about venlafaxine, and I'm just wondering if there's a general evidence-based approach, understanding that there's probably class effects. My first question. The second question is about the psychosis. So often we see people with visual hallucinations. They're on level carb or other medications. We wonder if that's causing it. We wonder, you mentioned sleep. We don't necessarily want to put them on quetiapine and certainly like sometimes clozapine or whatever. But what is the general approach then when someone presents to our offices with psychosis in the context of Parkinson's who are on medications, dopamine agonists?
Well, thank you for this important question, but I have to stick to the time, and it's about the closing time now. So what I want to do now is, first of all, to thank the speakers who really took the opportunity to extend their presentation with fabulous new information and going into detail on each question. I would like to thank the audience for being here and also for their questions. There are many more questions, and I will ask Chris to put the questions in the set apart so that they can be answered by the speakers after this meeting. And I want to thank the IPA office for organizing this. And I really want to emphasize to fill in the evaluation form because many of the themes within the webinars are chosen by you. So this is really important to us. And I think we are now at the top of the hour and we are about to close. So a big thank you to all of us for making this event very worthwhile.
Thank you. Thank you for having us. We appreciate it.
Very much so.
Dr. Madden, feel free to email either one of us with your question on the outside. We're happy to catch your last question.
If you're able to stick around an extra couple of minutes, I'm free, but whatever you'd like.
And maybe